My name is Lauren Powell. I'm the Emerging HIV Networks Coordinator with MDHHS, in charge of our internal and external response activities as it relates to the identification of increases in HIV through our monitoring programs. I'm here today with Jacob Watson, our epidemiologist, who is in charge of running the monitoring programs that allow us to look and see where there are disproportionate impacts of HIV in communities in real time. So with that, we really wanted to focus a little bit today about our shared HIV networks program, which is the molecular HIV surveillance program through the state of Michigan, and how it works and how we utilize that for information to better understand transmission in communities and work to interrupt transmission and make sure we're getting resources where they need to go. Just to start, we always like to do just a little bit of background. So these are things that folks are pretty much aware of. But, in Michigan, Michigan is considered a mid-morbidity jurisdiction. We have approximately 650 new diagnoses of HIV annually. In the last 5 years or so, from 2021 to now, we have seen 20 different HIV networks. And as we'll kind of talk about, there are some different methods we utilize to identify new networks or increases in HIV. These can include our shared HIV networks program, which is our molecular HIV surveillance program, which is what we'll be focusing on mostly today. We've seen 12 of those networks since 2021. We've also seen 5 time space alerts, so that's just an increase in new diagnoses over time in a given region. And we've also had 3 local alerts, which are kind of like just local providers acknowledging something happening in their community or where they're seeing something that's unusual that rises to the level where we're then activating a response. So we've been doing time-space analysis since 2015, and we started molecular HIV surveillance activities in 2016. So these really ramped up, especially around the Scott County, Indiana increase in HIV cases that we're seeing. That was where we really started monitoring for time-space networks, really looking at them monthly, quarterly, and just making sure that we're looking at a more timely fashion than annually to really see if there are increases occurring so that we can then organize response efforts and make sure we're getting care and resources where they need to go. Along with this, we have also, my position, the Emerging HIV Networks Coordinator position, was brought on board in June of 2021, and that's really trying to make sure that we're creating pathways to share data and information so that when Jacob's running the monitoring programs, we're really making sure we're utilizing that data, getting in the right rooms, making sure that we're presenting it to our local partners, being a part of the conversation here today. We also have onboarded a Emerging HIV Networks interviewer and outreach coordinator. The network conducting interviews and compensating them for their time to really understand their experiences and really to help to bring in that information to gain a better understanding of where we can interrupt transmission and really fill in gaps in prevention and care that are in our communities. Along with that, we also have our Michigan Community Outreach and Response Engagement, or MyCore evaluator, and that's really looked at evaluating the effectiveness of these programs and really making sure that we're doing things in a way that is having the most impact. So, when we talk about ending the HIV epidemic, I know we've all kind of seen these pillars, but response is really where the network detection and response program falls in. And one of the things we always like to emphasize is that response, really to be effective, needs to be impacting these other pillars. Response, we're both responding to networks, but we're also acknowledging where there may be gaps in services, whether that's with diagnosing individuals, treating individuals as early as possible, and making sure they're able to successfully maintain viral suppression, as well as preventing new HIV transmissions through interventions such as pre-exposure prophylaxis or syringe service programs. So one of the things we always like to emphasize is that response can't operate in a little vacuum on its own. It has to be interconnected with all of these different things in order to have an impact and really make sure we're getting services where they need to go. One of the things we always like to kind of emphasize is that we have multiple different techniques that we use to detect networks or to kind of monitor and see where there are increases in HIV. One of those is surveillance diagnoses, just looking at, and this is kind of where we talk about time-space networks, and that's really looking at the number of new diagnoses over time in a given region. It could be prosperity region, city, county, and we look at that both monthly and quarterly compared to some standards to really see if there is an uptick or an increase that is identifiable. We also have partner services. So just the typical partner services where we're seeing connections between individuals as part of those services. We also have providers and community members. A lot of times providers and community members, they're the front lines. Y'all have people who are seeing things happening in your communities in real time and really have an understanding of where something's standing out. And that can be really helpful for us to understand where there are things that we need to focus on or where we need to be surging things in order to have the biggest impact. And then what we're really going to delve into a little bit more today is our shared HIV network data, or our SHiNE program. And that's really looking at molecular groups that are linked via their viral RNA, where there are linked cases. And that really helps us to understand where there is recent and rapid transmission that can be an indicator for a need for services. Jacob?
Thank you, Lauren. So first, kind of the background of what SHiNE is and how it works. So, like Laura mentioned, SHiNE is the word we use to describe our molecular HIV surveillance program. So, Shared HIV Networks works by comparing the information gained during resistance testing. So you go in, you get your CD4, a viral load. You also get a resistance test, the standard of care for HIV across the country. Really, this helps doctors determine what medications might work best for someone with a particular strain of HIV. This kind of analysis has been done for multiple other diseases, including flu, hepatitis, and TB. That HIV genotype test that a doctor performs generates an HIV nucleotide sequence, which is kind of like a snapshot of what the virus looks like at that time the test was given. And it's important to note that it's a snapshot of the virus. So it's what the virus looks like, not the person's DNA. Nothing about the person is attached to it besides the fact that that person is getting a test. The actual genetic data is from the virus. And because HIV mutates at a consistent but rapid rate, we can make comparisons. So we can basically, if you go to the next slide, we can take all the sequence data we have and we can compare it to each other. And we can say how closely related two sequences might be. And if they are very closely related, then we can draw a connection between them. And again, it's a kind of a snapshot of the HIV virus at that particular time they got that genotype test. So that's what we're comparing between all these sequences we have. And if they are very closely related, we can draw a link or a connection between the two. And the CDC provides us the programs to be able to make these connections at the local level. I'm talking about a link. There are a few things that may go through people's heads. The first one, go to hit next, is if person A was diagnosed first and person B was diagnosed second, and we had a link between them, it must be that person A transmitted person B. That's not necessarily correct. It could be, that could happen, but it could also be person B transmitted to person A. It could also be person A transmitted to person C, who transmitted to person B. It could even be person D transmitted to persons A and B. Persons A and B may not have any idea who each other are. All we know is that the genetic data from that virus is similar because transmission from person B happened at a similar point in time. So the really key takeaway here when you're talking about these connections that we can make and how we kind of build these SHiNE networks is we can infer, so we can say or think that there is either a direct or an indirect epidemiological link. We cannot infer or decide on any directionality. All we know is these people in these SHiNE groups are somehow linked by this epi data. We can't say whether it's direct or indirect. All we know is there's some connection between everyone in these SHiNE groups. There's no way to infer directionality, and we do not infer directionality. So why are we focusing on SHiNE groups? Like Laura mentioned, we have 3 other tools we use to detect networks in Michigan. We can look at new diagnoses, we have our astute providers, and we have our keyed-in community members. So why are we using SHiNE as well? SHiNE networks represent fast and recent transmission networks. So when I was talking about making those links, those connections, we make sure that these sequences are very closely related. So there hasn't been time for the HIV strain to evolve that much. We make sure they're very closely related, so which helps us infer recent and rapid transmission. In addition, we limit these SHiNE groups to a CDC designation. There must be 5 persons newly diagnosed within a 12-month period who are all connected to create a SHiNE group or a SHiNE network for us to intervene on. And so you may be thinking also, well, how do we know these networks represent recent and rapid transmission? I've been saying that they do, and I say we use a type genetic distance threshold. Basically means how connected these sequences are. But how do we know? What data backs it up? So to kind of put that into frame, what you're seeing here is the HIV transmission rate in the United States. The HIV transmission rate in the United States is around 4 transmissions per 100 people living with HIV per year. So this is around 4 transmission events for every 100 people living with HIV in a given year. Here you can see it simplified down to 1 transmission for 25 people, but 4 to 100, 1 to 25, same thing. I just wanted to show you the visual representation of what this looks like on average in the United States. What we will see next is the range of HIV transmission rates in the United States. The range of HIV transmission rate in the first 60 priority SHiNE groups. So the CDC 6 years ago now looked at all molecular data nationwide, all the data they can look at for this SHiNE data, and they identified 60 priority SHiNE groups. And so the range of these groups was between 21 and 132 transmissions per year per 100 people living with HIV. So you can see here, displayed here is the largest group, 132 transmissions per year. That's over a 30-fold increase from the national average. So you can see that these networks represent a much higher potential of transmission events than the national average. So that's why we focus in on these as a tool. If this SHiNE groups and SHiNE networks didn't have a purpose to be used as a detection device, we wouldn't be using them. But this kind of goes to show the importance of them really keying in and identifying groups of people that may be associated with, or networks that may be associated with recent and rapid transmission of HIV, so we can then intervene and hopefully slow the growth or expansion of HIV in that particular network, which segues nicely into what Lauren will get into, which is, okay, we know we have this. What do we do? How do we intervene?
Yeah, and like Jacob said, so we have a lot of data and everything, but one of the things we always want to recognize is that data does a lot of things, but it doesn't intervene, it doesn't make change, it doesn't get services where they need to go. So the importance of data is in how it's used or how it's utilized. An effective intervention and response effort, it can't be based on data alone. It can't be based on one set of data alone. One of the things we always like to emphasize is that SHiNE is one piece of kind of the puzzle of surveillance and really understanding and utilizing these different technologies to understand where there are disproportionate impacts of HIV occurring. But it doesn't replace or negate the other ones. We're still using the time-space analysis, and all of them work in conjunction to make sure that we're understanding and focusing resources where they need to go on those that are the most impacted. We always say, like, no single approach or intervention is enough. Interventions and outreach, they have to be client-centered. They have to account for the needs of the whole person, not just HIV. They have to be dynamic and flexible to fit the needs of the community, and they have to be collaborative. So, like, really, we have this information, we're utilizing this data, but really what's important is how we're utilizing it to bring it together to really bring forth services. Kyra, I see you had your hand up.
Can you please explain prosperity region?
Yes. So prosperity region, it's a little bit of convenience sample. So it's something that's been utilized by the state of Michigan for looking at economic regions, and it serves as a useful tool to kind of break down different geographies and counties. So in Michigan, there are 10 different prosperity regions. So for instance, Prosperity Region 10 is what encompasses Detroit, Wayne County, Oakland, and Macomb County. So that's like Prosperity Region 10 in Michigan. So it's something that's been used in other programs, and we've utilized that as an effective way to kind of break down and look at diagnoses regionally. So we're always looking at any diagnoses every month and every quarter, looking at it by prosperity region. So we're looking at these different regions to see if it's above what has been the average previously, as well as county level and city level. But one of the biggest things we've learned just with network detection and response in general is that collaboration and leveraging existing partnerships is key. Just having data and information doesn't do a whole lot of good, but being able to utilize the information to work with different partners, whether community-based organizations, local health departments, that's really important. Additionally, leveraging key champions within communities, understanding and working with individuals who are on the ground, really making sure that those influences are in any response effort, recognizing what we know, what we don't know, and that communities have resources within them, and just recognizing and supporting those to really make sure we're bringing things forward. Additionally, community engagement and work with local partners to establish services and implement programs are essential. Any successful response efforts we've seen, that's really been the key, is that there is support from the state level looking at data, information, and resources, but that, individual and local organizations are the ones who are really delivering those services in real time, and really recognizing that importance. And then just making sure that there's clear communication among partners and the public. One of the big things we like to emphasize is that, with network detection and response in general, it needs to be consistent, it needs to be authentic, and it needs to be transparent. And I think there's always further we can go with all of those different elements, but really trying to make sure that that's how we're approaching this work when it comes to shared HIV networks or other network detection and response capabilities and surveillance in general. That at the end of the day, and that's really where, using networks instead of clusters, it's a really intentional choice, because these are individuals. These are not clusters, it might be the nomenclature, but these are individuals, and every person is a story. Every person is a part of the community, and really trying to recognize and elevate that in the ethos of how we're responding and making sure that we're implementing changes. So with that, thank you. Really appreciate the opportunity to be able to talk to you all today. Really appreciative, and definitely look forward to any questions. So I will open it up to folks.
How do you guys protect the information that you guys collect from people that are positive?
State of Michigan, we treat all data, whether it's all data around HIV, whether it's network data or someone's status, with the utmost care. We really ensure that we take all data security and protection matters seriously. We collect the minimum amount of data necessary, and to ensure that, and we also make sure that the access to these systems by people at the state is limited to only those who need access to that data. We do routine audits of those people who have access to that data, and if we have any kind of data sharing agreements, they have to be vetted and really kind of given the stamp of approval before anything is shared out. And we have annual security and confidentiality trainings, as well as an oath of confidentiality for all state workers. So we really ensure that this data is kept in the most secure manner.
When we're sharing it too, we also make sure that we limit it. So, you're not getting like line lists of individuals. We're making sure that things are, if they're under a certain amount, like if there's less than 5 diagnoses in a given region, when we're presenting on that, we make sure that that is taken into account, and just really making sure that we're following all of those standards for reporting, and really making sure to emphasize that we're utilizing this information directly in relation to response efforts, but that the proper people have the information and the minimum amount necessary to be able to act.
I think if you look at kind of how HIV, like how state of Michigan really store this data is very secure, and the SHiNE network is just one aspect of the data that we secure and manage. So yeah, I think as a whole, you could consider how we manage HIV through a public health intervention as kind of like that, but specifically with the SHiNE data, it's kind of a subdivision of that overarching how the state of Michigan manages and secures data. Yep,
Okay.
that is one of the
That's
things that we work with. This particular SHiNE data doesn't directly, but this general HIV, the reason the state collects this data, MIDAP is one of those systems that this HIV data does help and aid with what it does.
When these SHiNE networks are identified, or we see that there are 5 individuals who are connected within a year, one of our first steps is to really collect the information, look at our different databases, whether that's our partner service through a firm, Careware, and the EHARS database. So really making sure that we have that information and really taking into account what those interactions have encompassed. Also tying them in when we're formulating response efforts, talking to DIS to get further insights, making sure to take into account what their experiences have been. And additionally, that's something that we really want to recognize, that I think it's something that has been missing, and that we're really excited to have Kaylin Carter on board as our emerging HIV Networks outreach coordinator, or interviewer, which is somebody who can conduct re-interviews with individuals who are a part of networks, because a lot of times when you're a part of a SHiNE network, you have already had your partner services, because it just takes a little bit for that information to come through. So we really want to talk to people and make sure that we're taking into account kind of the full array of their experience, compensating them for their time. There's a $50 gift card compensation for engaging with us as part of these re-interviews, so that we can really bring some of those different elements, because I think it really speaks to the stories, and that's where you really get into what are some of the underpinnings. Because we know when we see networks or we see increases in HIV, it represents a breakdown in our care and prevention systems. Something is out of place, or something is not working properly, and that's not saying like agencies or anybody are doing it. It's something that we collectively can look at, and then it's just kind of about trying to utilize that information in the best way to identify where those gaps are, and then stand in those gaps and make sure people have the services they need.
Do you all know of any programs specifically that have been created because of this? The second question is this program being led by people living with HIV?
Thanks, Lawrence. No, I think that's an excellent question. I mean, definitely. And one thing we always like to emphasize with response is that response is a piece and it's a component of the effort. So, for instance, the Pull-Up Project. SHiNE did not create the Pull-Up Project. Absolutely not. But SHiNE played a role in identifying that there was an increase in cases, that there was a need, and that an initiative such as the Pull-Up Project, or bringing together all those different partners, was an important component and something to focus on in terms of that response overall. So, for instance, that's one of the better instances I can give of network detection or response. An additional one, and granted, this wasn't a SHiNE network. This was more in our just network detection and response, but we saw a few cases in a rural community in Western Michigan, in Montcalm County, that had there were persons who inject drugs who had been diagnosed with HIV in a very short frame of time, and we were able to use that information to work with the medical director in Montcalm County and get their board of commissioners to approve syringe service programs in the county, and then work with providers, Grand Rapids Red Project on the west side of the state, to work to set up a local agency to operate as a syringe service program. So those are a couple of examples of where this data has been utilized in a way, and not just the data, but utilizing the data as well as the array of just meeting with different partners and kind of guiding those efforts to bring something forward into the community that really works to address the needs. When we are identifying networks, one of our first, we are always trying to connect with our local health departments as well as our community-based organizations to really make sure to center them and the community within those responses, as well as within our understanding of networks, and what are some of the different experiences of people within those networks, because we're always trying to both connect with individuals who are part of networks to get them the services they need on an individual level if there are additional services they're not receiving, while also identifying some of these bigger picture gaps that they are witnessing within their community, to be able to kind of fill in some of those gaps and be able to make sure that we're delivering things in a way that is appropriate. And candidly, I think we have further to go. We work a lot with SEMHAC. I think there's definitely a lot of room for growth with SEMHAC and just being able to regularly share information and talk about when we're seeing networks. I know I've given a lot of, I'll give the information updates to Kyra to share, but we're also always happy to talk about what we're seeing and kind of what are some of the challenges and different things we're facing. Because I think that is an important step and component, is making sure that the voices of people living with HIV are at the forefront of the work that we're doing.
MIPA and GIPA, the meaningful involvement of people living with HIV and AIDS, and the greater involvement of people living with HIV and AIDS. Thank you. Yes.
Absolutely. Agree 100%. And we're also always happy to reach out to have individual conversations, because, this is a topic that really deserves a lot of breadth, and there is a lot of nuance within it, both positive, negative, and ways that we can utilize this information. So really appreciate everybody listening and engaging with us on this topic.